Thank you, sir, for your motivating speech and for welcoming. Now, I would request our medical doctor, Dr. S.N. Kadam, sir, to felicitate our resource persons. I would like to call upon Dr. Jayashree Ganekar, ma'am, for her unlimited support and encouragement when we went with the proposal to her and asked her suggestions for the resource persons, and she has given her a team of members for a few topics. I would like sir to felicitate, ma'am. Thank you, ma'am. Now I would like to call Mrs. Ashima Bhattacharya, ma'am, to come on stage. And thank you, ma'am, for accepting our invitation and raising this occasion. Now I'd like to call upon Dr. Samir Kadam, sir. Thank you, sir, for your support. Now I'd like to call upon Dr. Vishwas Sathe, sir, to please come on stage. Thank you, sir.
Good morning to you all. Distinguished dignitaries, invitees, delegates, colleagues, and dear students. We have reached the end of this short inaugural session, and I deem it a great privilege and joy to propose the vote of thanks. It is said that a smallest act of kindness is worth more than the greatest invention. With this quote, I take this opportunity to thank Honorable Chancellor Shri Kamal Kishore Kadam sir in absentia for being a great guiding light to all of us. We express our gratitude to our distinguished guest of honor, Lieutenant General Dr. S.K. Kaul, Professor, Department of CVTS, MGM Medical College Hospital, for gracing this occasion. Thank you, sir. We take this opportunity to extend a sincere thanks to Dr. Shashank Dalvi, sir, our Honorable Vice Chancellor, for guiding, supporting, and encouraging us. Thank you, sir. I'm extremely grateful to Dr. Sudhir Kadam, sir, Trustee MGM Trust and Medical Director. Since the inception of each and every nursing institution, sir has constantly been encouraging and guiding us in all our endeavors in numerous ways. Thank you, sir, for gracing this occasion. A heartfelt thanks to our dear Dr. Jayashree Ganekar, ma'am, Dr. Sabita Ram, Dr. Mansi Thakur, Mrs. Elikoti John, Dr. Samir Kadam, Dr. Vishwas Sathe. I take this opportunity to extend a most sincere thanks to all our guests and invitees who have come from different destinations to gracing this occasion. A heartfelt thanks to IT department, a food service, and a non-teaching department for their cooperation in organizing this event. Before I could conclude, let me thank the God Almighty for blessing this program. Thanks once again.
Now I would request all the dignitaries to be on the stage for photo session, and I would request learn by doing them. Now we will proceed towards our first session, cardiac system assessment. For this session, I would like to introduce Dr. Samir Kadam, HOD and Professor, Cardiac Vascular Surgery, in charge Director, Skill Laboratory, MGM Hospital and Medical College, Navi Mumbai. Sir is presently Associate Professor, Cardiac Thoracic Surgery, MGM Medical College. Sir has received AHA, BLS, ACLS, ATLS instructor and he has also specialized in various skill-oriented courses. Sir has done numerous number of paper presentations and publications. He has been rotated through various subspecialties surgical such as cardiac thoracic surgery, vascular surgery, colorectal surgery, hepatobiliary surgery, liver transplantation, urology, and renal transplantation. He is proficient in performing cardiovascular operations independently and also competent in managing patients in critical care. He is also well versed with general surgical procedures and have attended and contributed in various multidisciplinary meetings and audits. So today we have so privileged to have such a talented and expert personality to start with the session. Sir, I would like to call you to start the forum.
Morning, ladies and gentlemen. Thank you very much for coming for this course. My name is Sameer Kadam. I'm a cardiac surgeon, and as Madam has already introduced me, I'm also the director of the MGM Skills Lab. I have the great honor and privilege of presenting to you. This is the first time I'm actually presenting to nurse practitioners, so I've had to rejig my, my presentation. I'm very used to presenting to medical students, so hopefully I've got the balance right. While I'm doing this, if at all you feel that I'm going too deep into something, feel free to just get up and tell me that, you know, this is nonsense and move on. However, if you feel that it's too superficial, please let me know either way, okay? Okay, I'm going to be taking the first 3 sessions, cardiac assessment, ECG interpretation, and we'll do a group activity on ECGs as well. It's very difficult to cram all of the cardiac assessment as well as ECGs into 2 hours, okay? So I'm going to do my best. A lot of you are probably critical care nurses who work in cardiac units. Any of you working in cardiac units? No one? I was hoping I would get some help in my presentation. Anyway, fine. If anyone has any questions, please stop and ask. Otherwise, we can take questions at the end, either way. Fine. So we'll start with the assessment. So a brief overview of what we're going to be talking about today is, initially I'll just talk a little bit about the anatomy and the physiology. We'll talk about how you take a focused cardiac history, the general examination, which is important with cardiac histories, and the actual cardiovascular examination with inspection, palpation, auscultation, with special reference to heart sounds and murmurs. Now, I'm actually going to skip over some parts of the examination to save on time, but I'm trying to focus on very practical points, and I hope that you will gain from this experience. Okay, if there's anything that you want me to talk about in further detail, please ask. Okay. Before we start, amongst the organizers, I have 1 hour, right? 1 hour for this presentation? 1 hour. So if someone can just tell me in half an hour, then I'll know how quick or slow to go. So starting with the cardiac anatomy. So all of you are graduate nurses, so you're all aware. You have the superior vena cava, the inferior vena cava, going into the right atrium, which drains into the right ventricle, which goes into the pulmonary artery, going to the lungs, the oxygenated blood, and that will eventually get oxygenated the lungs, come back through the pulmonary veins, into the left atrium, into the left ventricle, and out into the aorta. Everyone's happy with the entire circulation aspect, if I take it. You have 2 coronary arteries, the right coronary artery and the left coronary artery, which divides into the left anterior descending and the left circumflex artery. So if you open up the heart, again, right atrium, okay, receives SVC and the IVC, and it goes to the right ventricle. Between it is something called the tricuspid valve, and between the right ventricle and the pulmonary artery is the pulmonary valve. Again, coming backwards from the pulmonary veins, oxygenated blood into the left atrium, separated from the left ventricle by the mitral valve, And from the left ventricle, it goes on to the aorta, separated by the aortic valve. So it's essential that you understand this basic anatomy. I'm sure you all know this, but sometimes people are scared to ask a question, so I just wanted to run over this initially. Beyond this, we have the conduction system. Everyone is aware of the conduction system basics. You have the SA node, which is the pacemaker of the heart. This is not exactly nerves, this is just excitable tissue. Okay, so SA node, which creates impulses, electrical activity, goes via various internodal pathways to the AV node. From there comes the bundle of His, divides into the right and the left branches, which eventually will supply the ventricles through the, not supply, they pass on impulses via the Purkinje fibers. Okay? Now, this is basically what a basic ECG. Everyone has a reasonable idea about ECG, PQ, RST complexes. I'm taking it for granted that you know that. So the P wave is when the atria get depolarized. Okay? The QRS complex is when the ventricles get depolarized. And the T wave is when there is repolarization of the ventricles. Simple basics. Okay? A little bit about the cardiac cycle before we move on to the actual assessment. The reason I'm going through all of this is because unless you know these actually basics, it becomes difficult to proceed. So essentially, the cardiac cycle, I'm going to start with, there's a lot of different sub-steps to this, but I'm not going to skip over those, okay? So basic cardiac cycle, the mitral valve, which is between the left atrium and left ventricle, it closes, and that's when systole starts. Now, we talk about systole and diastole in reference to the left ventricle, okay? We're talking about ventricular systole and diastole, essentially. So when the mitral valve closes, the ventricle starts to contract, and that is called ventricular systole, okay? Over here you have 3 lines. The red line is aortic pressure, the blue line is ventricular pressure, and the green line is the atrial pressure. So, when the mitral valve closes, the ventricle starts to contract. As you can see, the left ventricle pressure shoots up, okay? Blood is ejected into the aorta, and by the time it's coming to the end of systole, the end of the contraction, the pressure starts to fall roughly about 80, which is about the diastolic blood pressure that we have. When that happens, and that's the aortic lower limit of the pressure, 80. When it hits that pressure, the aortic valve closes, okay? So that is the entire length of the systole in the cardiac cycle, and this is about 0.3 or 0.4 seconds. After that, the ventricle starts to relax. That's called diastole. And it keeps relaxing. Meanwhile, the atria start to fill up the ventricles with blood. So the atria are contracting during this period, but the ventricles are relaxing. And a time comes when the ventricles are completely full of blood till it comes back to here, and the mitral valve will close again, and the ventricular contraction will start again, okay? So this is, in short, your cardiac cycle, okay? Systole, about 0.3 seconds, diastole, about 0.4 to 0.5 seconds. So the entire cardiac cycle is about 0.8 seconds, okay? And these, again, are divided into all sorts of small isovolumetric contraction, isovolumetric relaxation. We're not going to go into all of that. Everyone clear with this? Cardiac cycle, basic cardiac cycle. Okay. Now let's move on to a focused cardiac examination. The good thing about cardiac assessment is there's very few symptoms. There's only about 4 or 5 symptoms that a patient with any cardiac pathology will present with, out of which the top 3 are probably the most important ones. So chest pain. Anyone with any cardiac pathology, whether it's ischemic heart disease, whether it's some valvular disease, many of them will come to you and say, I've got chest pain. Okay, and that will start off. So that's one of the first main symptoms. We'll go into more details about that in a minute. The next symptom is dyspnea, breathlessness. Okay? So, and the third symptom is syncope. Okay? So with angina, syncope, and dyspnea, With these three symptoms, most of your patients will present with one of these or a combination of these, someone with cardiac pathology, okay? So as a nurse practitioner, if someone comes with saying, I've got chest pain, I've got breathlessness, does everyone understand what syncope is? It's fainting for no apparent reason. You're standing up, suddenly you faint, and then you may get up again. Loss of consciousness, a brief loss of consciousness, okay? And it is due to a decreased perfusion of your brain, okay? So these three symptoms is the hallmark, the main symptoms that happen in most cardiac patients. Besides that, patients can also have palpitations. They can have edema, okay? Edema, especially when you look at their ankles, they'll say, I've got puffy feet. If it's a bedridden patient, he may have edema on his sacrum. Okay, these are things to remember. Now, when it comes to dyspnea, this is, again, a very important symptom. So this has been classified in many different ways. There's something called the New York Heart Association classification. Dyspnea is divided into 4 different types, 1 being the mildest, 4 being dyspnea at rest. Even at rest, you have shortness of breath, okay? We're not going to go into a lot of classification because it's just theoretical, but what I want you to understand is a more practical base to this, okay? There's something called orthopnea and PND, paroxysmal nocturnal dyspnea, which we'll talk about as we go along, okay? So essentially, and lastly, hemoptysis. Certain cardiac conditions, you can also get what you call hemoptysis. If you've got long-standing mitral stenosis with back pressure changes, pulmonary pressure, you can get hemoptysis as well. So essentially, these are the main cardiac history features that you'll be aware of, which the top 3, as I said, are the most important. Okay. Now, for the purpose of this workshop, I'm going to be concentrating on adult cardiac disease. However, once you're nurse practitioners and you go out into the world, you will get a big cohort of cardiac diseases, actually congenital cardiac disease, okay? And they present very, very differently, okay? So you'll have mothers coming with their children, talking about one of these kind of symptoms. They'll say my child always gets chest infections. Every 2 months he gets a chest infection. He's been on antibiotics forever and ever, okay? Failure to thrive. Child is not growing. Despite feeding, despite everything, the child is not growing. Problems when they're feeding. So if a mother comes to you and says, when I'm feeding my child, he gets breathless, he's sweating, he's getting funny kind of turns, keeps crying, think he may have heart disease, okay? Needs a workup. Cyanosis, this is a big one, okay? If cyanosis is not normal, okay? If someone does everyone understand what cyanosis means? It's a bluish discoloration, okay? And it's generally due to deoxygenated blood going on the left side into the systemic circulation, okay? Reduced hemoglobin in the systemic circulation. Squatting episodes. So a mother will come and say, my child has, when he cries or gets distressed, he goes blue, he finds it difficult to breathe, and then the way he sorts himself out is he squats or does some other kind of maneuver which he starts to get better again. And they're very, very categorical when they say this. Don't think of it as, okay, they're saying some rubbish, okay? If a mother is complaining that a child is coming and he's squatting and this and that, think he may have some kind of heart disease, okay? So these are symptoms of congenital heart disease, okay? But as I said, this particular thing will concentrate mainly on adult. So chest pain. So if someone comes with chest pain, what are you thinking? There are multiple reasons for chest pain, okay? You can have cardiac causes, which generally is ischemic heart disease in adults, okay? There's a problem with the coronaries, there's some kind of blockages, there's ischemia of the myocardium, and that gives rise to pain. Will usually be an older person, generally an older man, can be a lady as well after menopause, but generally an older man, okay? Ischemic heart. But there are lots of non-cardiac conditions which can cause chest pain. Can anyone name a few? Anyone? Anyone wants to name a few? Where's Priyanka? She's not here? Oh, Priyanka's there, yeah. Anything you can think of? Non-cardiac chest pain? Name one. Sorry? Anyone? Musculoskeletal pain. Good. Anyone else? Pulmonary embolism. Very good. Any others? Speak up. Anyone knows what an aortic dissection is? Anyone heard of an aortic dissection? Yeah. Okay. So anyway, for the sake of critical care, pulmonary embolism, good. Musculoskeletal pain, good. There's a whole list of them, and this is just a small list. Pulmonary embolism, as you mentioned, musculoskeletal pain, aortic dissection. These top 2 or 3 are life-threatening conditions. So as critical care practitioners, this is something that you need to be aware of, okay? If someone comes to you with chest pain, don't think, no, this is cardiac pain. Go to the cath lab, okay? Think of other reasons. Could it be an aortic dissection? If you have an elderly man with hypertension, different BPs in both arms, tearing pain down his chest and his back, think aortic dissection. Pulmonary embolism, someone who was fine a second ago, suddenly is short of breath with chest pain, maybe has had an orthopedic operation a few weeks ago, think pulmonary embolism. Has had a long flight, has had trauma to his leg, okay, think pulmonary embolism, okay? Someone who had a previous DVT and suddenly becomes breathless with chest pain, think pulmonary embolism, okay? Am I making sense? Yeah? Okay. GERD, gastroesophageal reflux disease, okay? So everyone knows what acidity and reflux and all of that is. It can sometimes give rise to not only abdominal epigastric pain, it can give rise to chest pain as well. So patient doesn't understand the difference between this is acidity and this is hard. They will come and saying, I've got chest pain. So it's up to us to assess, ask questions, okay? When does it come? Is it related to food? Is it a burning kind of a pain? Is it a crushing kind of a pain? Okay, are there any associated symptoms with it? Okay, so you have to keep an open mind when it comes to deciding on chest pain. Now let's talk about the reason why let's talk about ischemic chest pain. This is cardiac chest pain, okay? A majority of it is ischemic, as I said. What are the features of this pain? So, what will the patient come and tell you? As I said, suppose there's a 60-year-old man who's come into the casualty saying, I've got chest pain. Okay, how will he present? If he's got ischemic chest, he'll probably complain of a central crushing kind of a pain. Sometimes they won't describe it as pain, diabetics especially, okay? They sometimes don't get pain. They'll just say, I've got pressure, okay? And they'll generally hold a fist and say, it's hurting me here. If they're pointing with a finger, it's less likely to be this. That is very musculoskeletal kind of a pain, if they're pointing with a finger. But if they're holding a fist and say, I've got pain, they're finding it difficult to localize, think cardiac chest pain, okay? But it's not just pain. There are other associated features with ischemic chest pain. They may be sweating profusely, okay? So that's because of sympathetic stimulation along with the ischemia, okay? Along with the sympathetic stimulation, they'll start to sweat. So you and I will be absolutely fine, but someone comes in with the same temperature, and he's sweating profusely with chest pain. Think cardiac chest pain, ischemic chest pain. There may be associated nausea and vomiting, okay? So those are, again, features of ischemic chest pain. He may be breathless, okay? There may be radiation to the left arm or the neck or the jaw. Again, features of cardiac sounding chest pain, okay? And lastly, so for people who are already been on some kind of a treatment, or have seen a doctor, or already know they've got ischemic heart disease, they will say that, oh, I had this chest pain, I took a GTN spray, or I took a sorbitrate tablet, and the pain went away. Very, very indicative of cardiac chest pain, even though they don't have it at that point. So if they say they had chest pain relieved on this, very suggestive of cardiac chest pain, okay? Clear? Any questions about this so far? So let's move on to the next symptom, which is dyspnea, okay? So any patient that comes in with chest pain, many of them will come with dyspnea as well. Now, dyspnea can be dyspnea at rest, which is a grade 4, as I mentioned, which is something very, very significant is going on and needs to be admitted and treated then and there, okay? Don't send someone with dyspnea at rest home, okay? Many of them will not have dyspnea at rest. They'll say, I get dyspnea on exertion. Then you need to try and find out what kind of exertion. Okay, if he says, I get dyspnea on walking 5 feet or 10 feet. That is very significant. There's something wrong. You and I don't get dyspneic when we walk 10 feet. Okay? Some people will say I get dyspneic when I climb 40 stairs. Okay? Then you can take that with a pinch of salt. You and I will also get dyspneic. Maybe not you, but I will. I'll get dyspneic when I climb 40 stairs. Okay? So you have to have an open mind. Okay? You have to think and weigh the situation. So if you've got two people with breathlessness, one is saying, I'm get dyspnea at rest, one is saying dyspnea on 40 stairs, who will you look after first? Probably the chap who is dyspneic at rest. You will take that person seriously. Okay? Some people will say, I only get dyspneic when I lie down at night. Okay? So when I lie flat, I get short of breath. Okay? That's a very, very significant symptom. Okay? Dyspnea when lying flat. And it's a sign of advanced heart failure. So if you see someone like that, they need to be admitted, assessed further. Okay? Clear? Paroxysmal nocturnal dyspnea. Again, it's one less than orthopnea. Dyspnea comes in various grades or stages. So you start off with PND or just normal dyspnea on exertion. It will progress to PND. What happens in PND? You get sudden breathlessness which awakes the patient from sleep. So your patient will typically say, I go to sleep at night, in 2 or 3 hours I wake up feeling I'm gasping for breath, I'm choking. I have to run to the window and open the window and I feel like sitting up basically, okay? So this is PND, choking or gasping for air, should be, sorry, okay? So these are all different grades of dyspnea. Now, I'm going to move on. So these are essentially the things that you have to look at when it comes to cardiac history, okay? Very focused history, okay? Each of these we can go on talking for an hour together, but due to lack of time, I'm going to move on quickly, okay? Any questions so far? No. Fine. Now, physical examination. Whenever we do a cardiac examination, there's a way of examining a cardiac patient. We always want them to be stripped till their waist, okay? Get some privacy, obviously, especially if it's a lady, you want a curtain or something, okay? And secondly, we should have them sitting at a 45-degree angle. So raise the head end of the bed, make sure they're lying comfortably at 45 degrees, and then examine them in such a situation, in a nice quiet atmosphere which is private, okay? So you start off by taking your vital signs. I'm just going to run through these quickly. This is very obvious. All of you will know. Temperature, nothing new there. Now, there's a difference between heart rate and pulse rate. Okay? When you do a pulse rate, you're looking at peripheral pulses. Okay? So what pulses will you check? You'll check the radial pulse. You may check the brachial. You may check the carotid, femoral pulses, or pedal pulses. But when you're dealing with a cardiac case, you have to get the heart rate. So take a stethoscope, listen to the chest, and get the heart rate. There may be a variation between the heart rate and the pulse rate, okay? Suppose you see a patient with what you call radio-radial delay. Suppose you take the right radial artery and the left radial artery, and there's a delay. What does that mean? Anyone? So you'll have to speak up, I can't hear you. Yeah. Okay, so there may be some thing in the subclavian artery, there may be a coarctation, there can be all sorts of things, okay? Now you have something called the radioapical delay as well. Does anyone know what that is? Sridevi? No? Say again? In atrial fibrillation, yeah. Okay, you can get radioapical delay. So when you're doing a general examination, check the radial pulse, check the heart rate. You can check the correlation between the two as well. Okay, it's important. What is a water hammer pulse? So when you see someone who you suspect has got possible aortic disease, aortic valve disease, you check his pulse, okay? And then what you do is you check the pulse, put your hand on the forearm like so, and lift it. In a patient with aortic regurgitation, you'll suddenly feel a bounding pulse on the hand over here. Okay? And that is very, very pathognomonic of aortic regurgitation. If you see the next aortic regurgitation patient you see, try it. Okay? You cannot miss it. But we don't do it very often, isn't it? How many people have checked for water hammer pulse? Anyone has checked? No? Okay. Try it next time, whenever you see an aortic regurgitation patient. Okay? Blood pressure. So you check a blood pressure. As I've mentioned over here, you can sometimes have a differential blood pressure. A different blood pressure in the right arm, a different blood pressure in the left arm. I'm not going to go into how you take blood pressures. I'm sure you all know all those things. Okay? So if you have someone with differential blood pressure in the right and left, think, could this patient be having a dissection? Okay? If he's someone coming with chest pain, going down his back, different pressure in the right, different pressure in the left, hypertensive, old male, think dissection. Okay? The other thing is if it's a child and you see a different pressure in the arms, different pressure in the legs, think coarctation. Does everyone know what coarctation is? It's a narrowing of the aorta, a congenital narrowing of the aorta. Okay? And it's generally distal to the origin of your left subclavian artery. So that's why the pressure proximal to the coarctation will be normal, like in the arms. But distally, it will damp. Okay? If you see a patient with aortic regurgitation, one of the problems with aortic regurgitation is the valve doesn't close properly. And because of that, what happens? Remember in the first thing when I said the aortic pressure goes down to 80 and the valve closes? So when that doesn't close, the pressure keeps dropping. Does that make sense? Yeah, just think about it. If the valve doesn't close, the pressure that is built in the aorta just keeps dropping further and further. So when you see a patient with aortic regurgitation, okay, their systolic will be 120, 130, but their diastolic pressure, normally in you and me, considering we don't have AR, would be about 80. But in a patient with AR, their diastolic pressures will go pretty low, 30s, 40s, okay? So if you see someone with a blood pressure of 130 over 30, or 130 over 40, or something like that, think aortic regurgitation. Clear? Okay. Besides that, respiratory rate, nothing much to say about that. Oxygen saturations, another important one. If you find someone walking around with a saturation, especially suppose a child comes in, mother says he goes blue when he cries, and you put a oxygen saturation probe on, and you see the saturations are 86%, and the child looks absolutely normal. You have to think of possible cyanotic congenital heart disease, and then assess according to that, okay? So oxygen saturation. So all of these things, temperature, heart rate, blood pressure, respiratory rate, oxygen saturations, very important parts of the examination, okay? In other things like general surgery maybe or stuff, you won't pay that much of attention to the finer nuances. But with cardiac patients, you have to think. So if you see any of these, that's why I actually put them down. If you see a low diastolic blood pressure, if you see a low low oxygen saturations, if you feel a water hammer pulse, think of some kind of a cardiac problem and assess accordingly. Clear? Now we come to the general examination. Everyone does general examinations. You look at pallor, icterus, sinuses clubbing, lymphadenopathy, edema, and a raised JVP, right? Anything else? This is more or less the general examination of a patient. So with cardiac patients, the way I kind of change it slightly is, there's three things to look at. One, you look at their hands. Two, you look at their face. Three, you look at their ankles. So with cardiac patients, look at their hands, face, and ankles. So what do you see in the hands? Clubbing. Okay, and there's some other things on the next slide which I'll talk about. Okay, what do you look at in the face? You look for pallor, icterus in the eyes. Okay, by face, I mean face and neck. You look for a raised JVP. And what do you look at the feet? You look for edema. Okay, so if any of these are positive, think that there might be something wrong cardiac-wise with the patient. Okay, so rather than just mugging up pallor, icterus, sinuses clubbing, lymphadenopathy, JVP, look at the hands, look at the face and neck, look at the feet and see if there's any abnormality. If it's there, you will pick it up. A lot of doctors, at least, they kind of skip the general examination. It's a big mistake. There's so much of information, and it takes 15 seconds to do per patient. Look at the hands, look at their face, look at the feet, okay? You will miss things if you don't do it. A lot of doctors skip, okay? So, with respect to this particular workshop, I'm going to be concentrating on 2 or 3 of these, which are very high yield for a cardiac assessment. That is cyanosis, clubbing, and JVP, okay? The rest of them are quite self-explanatory. It doesn't change much from the non-cardiac patient to the cardiac patient, okay? Other things to look at, xanthelasma. Does anyone know what xanthelasma is? Yeah, so there are cholesterol depositions around the eyes and stuff, which are indicative of probably will, if he has these cholesterol depositions, he'll have cholesterol elsewhere in the coronary arteries, etc. Okay? So they will have possibly could have coronary artery disease. Okay? Malar flush. Does anyone know what a malar flush is? Anyone knows? Yeah. So when you see patients with mitral stenosis, it doesn't really, you don't see it a lot in our country because we're all dark-skinned people. But if you go to other countries where you have white-skinned people, Caucasians, and they have mitral stenosis, they get this rosy bluish tinge on their face, and it's there all the time, okay? So if you see that, one look at your patient and you can say, oh, this patient might have a mitral stenosis, okay? This is the importance of general examination. You just look and you can get a reasonable idea of what the diagnosis might be. But we don't see it a lot in our place. There's something called bacterial endocarditis. Has anyone seen a patient of bacterial endocarditis or heard of or read? No? So essentially it's vegetations that grow in the valves, bacterial vegetations that grow in the valve, okay? And these little bit of bacterial emboli, they break off and go to different parts of the body and cause all sorts of havoc. It's a very serious condition, okay? A lot of people die due to this, especially if you have bacterial endocarditis on the right side, the tricuspid valve. It happens a lot with intravenous drug abusers, okay? They inject themselves with unclean needles, and all that bacterial load goes into the right heart, and which is the first valve? The tricuspid valve. So it goes and sits there and causes destruction of the valve. So bacterial endocarditis. It can happen in other valves as well. So these are all Osler's nodes. What are Osler's nodes? They're painful nodules on the hands due to this septic emboli. Janeway's nodes. What are Janeway's nodes? These are non-tender erythematous papules. They're like little red marks that you see on the hands with bacterial endocarditis. I'll show you pictures of all these as well. Splinter hemorrhages. What are splinter hemorrhages? These are little blood clots underneath the nails that you see, vertical blood clots. Okay, anyone, you've seen splinter hemorrhage? You've seen them, right? Yeah, okay. Okay, finally, rot spots. What are rot spots? Anyone knows what are rot spots? So it's more of a fundoscopic examination with an ophthalmoscope. You look into the eye, and you will see little red retinal hemorrhages, okay? So all of these 4 are features of bacterial endocarditis. So, and all of these are seen on a general examination. So you see someone, when I say look at their hands, if you see someone with Osler's nose, Janeway's nose, splinter hemorrhages, you probably won't do an ophthalmoscopy, but if you see any of these, you have, just by looking at him, you get an idea that this patient may have bacterial endocarditis, even without doing the rest of the examination, okay? It will form a part of your differential diagnosis. So hence general examination, very important. Okay, let's move on to a very important one, that is clubbing. So how many have seen patients with clubbing? Yeah, a lot of you? Most of you? Yeah? Anyone who has not seen clubbing? Okay, fine. This is what clubbing looks like. Okay, now look at your own fingers right now. Okay, this is probably what your finger looks like. There's this angle between the nail and the nail bed over here. Okay, it's around 160 degrees. This is called Lovibond's angle. Okay, now in certain conditions, there are cardiac conditions, there are lung conditions, there are gastrointestinal conditions, thyroid conditions. You can get clubbing. A lot of different conditions can cause clubbing. Okay, but we're going to concentrate on the cardiac ones. So, what kind of cardiac conditions can cause clubbing? Congenital cyanotic heart disease, okay, can cause clubbing of the fingers. What else? People with lung cancer, they can get clubbing, okay? Fine. Gastrointestinal diseases, celiac disease, they can get clubbing. If you see clubbing, if you see someone's fingers like this, something is wrong. Do not ignore. It's not just beautiful nails. They're not actually quite beautiful, are they? Okay, fine. So if something like this is going on, something is going wrong. Okay? Another thing to do is ask them to do this. Put your nails together. Now, if you do it right now, you'll see that there'll be a little window here. This is called Shamrock's window. Whereas in a patient with clubbing, you'll see something like this. There is no such window. If you see something like this, think clubbing. Think something is wrong, possibly cardiac. Right? What about cyanosis? We've already mentioned. Cyanosis is essentially reduced hemoglobin in the systemic circulation, okay? Deoxygenated blood on the oxygenated side, right? Why would you get this? Can anyone give me an example of why you would get cyanosis? Cardiac-wise. Who gets cyanosis? Is it adults? Sorry? Children. Why children? Because they have, yes, congenital heart problems, okay? There are shunts. You have something called an atrial septal defect, a hole between the left side and the right side. A ventricular septal defect, a hole between the left side and the right side. And because of that, what happens? Generally, when the pressures are more on the left side and less on the right side. Generally, the blood travels from the left to the right, which is not so much of a problem, but slowly the pressure on the right starts to increase. And when the pressure on the right side of the heart increases so high that it's more than the pressure on the left, then blood starts to go the other way. So the right side, which is the deoxygenated blood, starts to go through the hole into the left. Clear? And then you start getting cyanosis, okay? Now there's two types of cyanosis. There's central cyanosis and peripheral cyanosis, okay? So what is the difference between the two? With central cyanosis, it's diminished arterial oxygen saturation. With peripheral cyanosis, it's basically diminished flow, okay? So if you go to a cold country, or you go to Kashmir, or you go somewhere, okay, and it's so cold and all your arteries have gone into vasospasm. Is anyone from Kashmir here? Anyone been in a very cold area where your fingers go blue? Has anyone experienced that? No? Okay, fine. So that's peripheral cyanosis due to the cold, or maybe due to some drugs or some vasospasm. It's a problem with the flow, okay, and that's why your fingers will look blue. Okay, it's peripheral cyanosis is diminished flow. It's on the skin only. Whereas in central cyanosis, it's on skin and mucous membranes, tongue, lips, cheeks. Central cyanosis has clubbing. Peripheral, there is no clubbing. Temperature-wise, as I said, it happens in cold conditions with peripheral cyanosis, where central cyanosis is generally a shunt or something across. People are warm, okay? Now, if you apply local heat in peripheral cyanosis, the cyanosis goes away. Whereas in central cyanosis, it will remain. Clear? What about the problem with this? The central is decreased oxygen saturation, right? So if you give them oxygen, the cyanosis decreases with central cyanosis. Whereas in peripheral, it stays the same. Clear? This is a picture of a central cyanosis where there's a little kid probably with a cyanotic congenital heart disease, okay, probably a tetralogy of Fallot or something. And if you look at his lips, look at his tongue, look at his general color, he looks quite blue, right? If you see this person, their fingertips are blue, okay? This is peripheral cyanosis, central cyanosis. Etiology, again, there's a mnemonic called cold palms. So for peripheral cyanosis, cold, any obstruction, left ventricular failure and shock, decreased cardiac output. All of these can cause peripheral cyanosis. Whereas with central cyanosis, things like, it's not necessary to mug up these, just remember shunt out of them. Shunt and lung disease, Okay, those are the important ones to remember. Okay, if you think of these, then you're thinking about heart disease. Let's move on to JVP. Now, I'm going to go into a little detail in JVP. How many of you are quite comfortable with JVP, the waveforms and stuff like that? Or is that important to you? It is important? Okay, fine. We'll talk about it. So if you see someone like this is why we have to lie them down at 45 degrees. JVP is always checked at 45 degrees. Okay? You lie your patient down at the backrest at 45 degrees, and then you can see the JVP, whether it's raised or not. What happens when the patient lies flat? It will probably be raised anyway. What happens when you're sitting upright? It will probably drop anyway, so you can't see what the JVP is. So you lie them at 45 degrees, and you will see what the JVP is. So you see someone with distended neck veins, think cardiac disease. This patient possibly could have cardiac disease. Okay? What other conditions can cause distended neck veins? Speak up, sorry. Atrial regurgitation. Okay, fine, I'll give you that, yeah. Anything else? Again, that is cardiac. Tamponade, who said that? Very good, fantastic. So these are non-cardiac problems. They can also